welcome everyone. Let's talk about the periodontium. So what is a periodontium? Periodontium is, as the word implies, everything surrounding the dontium, the tooth structure. So everything around the tooth itself. So that will only include four things. Those are your PBL, cementum, bone, and gingiva. Everything else besides these four components is not considered periodontium. So once again, PBL, cementum, alveolar bone, and gingiva. Next, if we look into this picture we have on the upper left, that one shows basically our periodontium components, such as you can see in the bony component we have the alveolar crest at the top of the bone. Then we have the cribriform plate, which is also called the alveolar bone proper, also known as the lamina dura that you see in the x-ray. So that is a white line that is formed around the tooth socket, and we usually measure bone loss with the lamina dura. Then we have the cortical plate, which is compact, and then spongy bone inside, which is called spongiosa. We have two types of cementum. We have the acellular cementum, which we usually find, not usually, acellular cementum is always found at the coronal region, whereas the cellular cementum is found at the apex. And cellular cementum is going to be thicker relative to acellular cementum. On the other hand, we have our PBL fibers. So PBL fibers, they will go in an order from top to bottom. So the first one we have is basically our alveolar crest fiber. That is the first one. It attaches straight from the alveolar crest to the acellular cementum. And as we are going down the list, we have number 2, horizontal fiber. Number 3 is oblique fibers, which are bulk of the fibers. And the last one is apical fibers, which go straight up. So oblique fibers, always just remember they are going in the occlusal direction from the tooth. So from the cementum, they are going up to the occlusal surface. Next, if we talk about the origin of the periodontium, we know that these are the, you can find them in the bell stage, the outer cells, known as the dental sac or the dental papilla. That is where you get all the components of periodontium. We also have other layers that we can review right now. So all of periodontium comes from dental sac and follicle, which is your PBL, cementum, bone, and gingiva. And then the other layers that we have in bell stage are basically the outer enamel epithelial. We have the stellate reticulum. We have the they have the gags or glycosaminoglycans. We have the stratum intermedium, which provides nutrients to the ameloblast or the inner enamel epithelial. So the yellow is your inner enamel epithelial. And then finally the orange is the odontoblast, which is the most outer. Then we also had papilla underneath that. So let's jump right into periodontium. Periodontium is a connective tissue organ. And then we will talk about the components. We'll talk about the alveolar bone, the PBL, and finally the cementum. And those are all the components of periodontium, and that is our lecture. So the first one we will talk about is periodontium itself. Like I said, it is a connective tissue organ that's covered by the gingival epithelial and attaches the tooth to the bone with this continuous adaptation apparatus. So what that means is that the bone, PBL, cementum are always remodeled with these mastication or occlusion forces. So these concepts because they're always remodeled, they are always in a continuous adaptation. So periodontium is always adapting to the whatever is happening to the tooth itself. The periodontium are the PBL ligaments which attach to the tooth. They attach basically into the cementum, and in the bone they will attach specifically into the bundle bone, which is on top of the alveolar bone proper, or the cribriform plate. So they go from the bone to the teeth. Teeth, they go into cementum, and then the bone side they go into the bundle bone. And I will show you a photo later of the bundle bone and the PBL fibers. Next we have cementum. Cementum, you have two types. Acellular, you found at the cervical, which is thinner, and cellular, which is found at the root or the apex, and which is thicker. Next we have components of the alveolar bone itself, the alveolar bone proper, alveolar crest, and then the cortical plate, as well as the spongiosa. Cribriform plate, also known as alveolar bone proper, in layman terms is your tooth socket, so anytime, as well as your spongy bone. So when you extract a tooth, once you look into that tooth socket, you will see a bone with holes in it, and this bone is the cribriform plate, and the holes are basically for nutrition, and those are the Volkmann canals, just like in the compact bone. So we have the Volkmann canal that provides nutrients. The bone where the tooth is sitting is called the cribriform plate, or the alveolar bone proper. Next we have some fibers. So circular fibers are part of the gingiva, whereas the alveolar crest, horizontal, oblique, and apical are the PBL fibers, and they go in that direction. So what are all these components can be broken down into two, so they can either be fibers or mineral. The fibers are the lamina propria, which is a bilayer connective tissue that is under the epithelial and the gingival ligament fibers. Whereas you have the PBL, periodontal ligament, which is also connective tissue found in the periodontal space, which all that means is it's in the space surrounding the tooth. Just like periodontium, this is periodontal space, so space around the tooth. Mineral component is our bone, so alveolar process, the maxilla mandible that is formed by the intramembranous bone formation. Intramembranous, unlike the condyle of the mandible, which is the only part formed by endochondral bone formation. Then we have cementum, which covers the root of the tooth, and we talked about cellular and acellular cementum. Once again, alveolar bone is your tooth housing. It is made up of alveolar and the basal bone. So alveolar is where the teeth is sitting. So if you look at the mandible, where the teeth sits, we will call that the alveolar part. Everything below that to the chin, the rest of the bone of the mandible is your basal bone. So here I've drawn, you have where the teeth is sitting is alveolar, and everything below that is your basal. So that applies on the maxilla and the mandible. So alveolar bone is for attachment and supporting the teeth. Alveolar bone is maintained by the PBL with a mechanical stress. And PBL is always remodeling with those bone cells, osteoblast and osteoclast. And so alveolar bone always have to be maintained by the PBL. And a clinical note is that if you lose teeth in a patient, you will get alveolar bone resorption. So you would want to place an implant or something ASAP so that the patient doesn't lose their alveolar bone. Cribriform plate, like we said, is also known as alveolar bone proper, and then it is lamina dura in the x-ray. That is the white line you see, and it usually tells us about the bone loss associated with the tooth. Bone loss of the tooth you can find from the lamina dura, and cribriform plate has those openings, the holes we talked about, and they are porous holes of Volkmann canals. because they are able to provide nutrients to our surrounding our tooth structure, basically. And cribriform plate is also where the PDL fibers will attach into. More importantly, they will attach on the bundle bone or the immature bone on the cribriform plate. So generically, it's attachment of PDL, cribriform plate. More specifically, the attachment of the Sharpie's fibers go into the bundle bone, which is next to the cribriform plate. And on the other hand, you will get the same Sharpie's fibers that go into the tooth, and they go into the cementum. So basically, on both sides, the tooth and the bone, you have Sharpie's fibers going into these structures, and in the middle, you have the PDL fibers. So if I have an order, you have cribriform plate on the bone, and you have the bundle bone, and then you can have some space, or you will find the PDL, and then finally the cementum on top that is covering our tooth root. So the PDL fibers, more specifically Sharpie's fibers, will start in the bundle bone, and you'll have PDL fibers in the middle, and then the same Sharpie's fibers will attach on the cementum in the tooth structure. The resting line, you see those show oppositional growth of the PDL, of the bone, I'm sorry. And then now, next we have, this is your spongiosa or the spongy bone. We know this is a trabeculae or trabeculae bone, which is always covered with compact bone on the outside. Spongy bone is never exposed. In other words, it is always in middle, sandwiched inside the compact bone. Next, we have basically bone formation. We know that the bone forms two ways, intramembranous and endochondral. Intramembranous bone formation in the oral cavity is for the maxilla and the mandible, most of the tooth-bearing area, whereas endochondral is for the condyle. So intramembranous does not need cartilage template for bone growth, and endochondral, as the word suggests, needs a cartilage template. And if we look at the cortical plate itself, we can say that the mandibular cortical plate will be thicker than maxilla. When we talk about maxilla itself, the palatal side of maxilla will be thicker because the bone is joined to the palate, whereas in the mandible, the buccal surface will be thicker, and the lingual will be thinner in the mandible. As well as the cortical plate increases in thickness as we go distally to the molars, as we go to the back. Once again, condyle of the mandible is the only thing in the oral cavity made by the endochondral bone formation. Then we have two septums that are made of the alveolar bone proper and the spongy bone. The septum separates adjacent teeth, so that is interdental septum for teeth. And then you have interradicular that separates a root. Radicular stands for root. Finally, PDL is what attaches the bone to the tooth with the help of Sharpie's fibers. The function of PDL is basically, so Sharpie's fibers go into the bundle bone, whereas in the tooth they just go into the cementum. The function of PDL is attachment and support of the tooth. They also produce collagen bone cementum during the repair process, so cellular cementum can be added if there's injury. The nutrition that you get for PDL is the dental branch of the alveolar arteries. And finally, the most important concept of PDL is proprioception. Proprioception is having the sense of space and movement. So when our tooth feels a pressure or we bite too hard, when the PDL fibers stretch beyond their limit, they're the GPS system for the body for pressure. That is how you get pain and pressure found in the PDL fibers. The type of fibers that you find in the PDL is it's made up of the collagen, which is type 1, 3, and 12. So the way I remember is 12 and 13. And you can find a better way if you like. So 1, 3, and 12 collagen fibers in the PDL, and then other is oxytalin, which all it does is an elastic fiber that supports the blood vessels. That will come in handy later on. So if we talk about the zones of the PDL is in between the tooth and the bone. More specifically, it's found near the cementum, between cementum and the bone. So the area of the PDL around the cementum, we'll call that pericemental zone, and the area around the bone, we will call that the periosteal zone. And in pericemental zone, you find the cells of the cementum, so cementoblast and cementoclast, whereas in the periosteal, you find bone cells, osteoblast and osteoclast. The most important zone here is the intermediate plexus, which is important for eruption because as the PDL fibers change orientation or direction, they break apart and reattach. This is where all of that happens, in the intermediate plexus. Because once it's anchored in the cementum bone, they kind of stay there. Now let's talk about each of the PDL fibers, and this will go in order from top to bottom, or from coronal to the apex or the root. So let's start with the most upper top fibers. You will find at the alveolar crest. This is wrong. So basically, because the last one is not at the root, so it's only 1 through 5, you will go from coronal to apex. The first one is alveolar crest. As the name suggests, it goes from the alveolar crest up into the acellular cementum, or the cervical cementum. And the job of the first two PDL fibers is to oppose lateral forces, side to side. So alveolar crest and horizontal oppose lateral, whereas the bulk of the fibers are called the oblique fibers. And most of these fibers, they do the bulk of the oral cavity's work, which is mastication or occlusion. Then we have our apical, which is all the way on the bottom of the root, and they go straight up from the apex to the alveolar bone and prevent tipping. Intraradicular also prevents tipping or torque. Intraradicular meaning inside the root, so it is where you have bifurcation or you have multiple roots. So it goes from the intraradicular septum to the root furcation. And then finally, these transeptal fibers, we just throw them in here. This is what joins adjacent tooth to tooth, and the cervical cementum of one tooth over the dental cementum, and then attaches to the cervical cementum of the other tooth. Now let's jump into gingival ligaments. These can be confused sometimes with the PDL fibers. So the ones we talked about up top were PDL fibers, that's around the tooth, whereas these ligaments help the gingiva anchor in its place. And they basically go by the name, tells you the location. So dentogingival meaning dental tooth to the gingiva itself. So dentogingival, tooth to gingiva. Alveogingival goes from the alveolar crest to the gingiva. And we have dentoperiosteal, goes from the tooth to the gingiva. Tooth to the periosteal layer of the bone. And circular always wrap around the tooth, like in a circumference. This is important because these are the fibers you'll find around the implant, because an implant cannot have penetrating of these gingival ligaments. So the only thing that works is that you have these circular fibers that are able to attach themselves around our implant and keep it in its place. Next, let's talk about the cells that you find in the PDL, and which is very simple. The only cells you find in the PDL is the fibroblast, which make and break down collagen. You have the bone cells, osteoblast and osteoclast. You will find that in the periosteal zone. And then finally, cementoblast and cementoclast. You will find that in the pericemental zone. So once again, the cells are fibroblast, bone, and the cementum cells of PDL. We have interstitial area, which is like a cytoplasm or a watery fluid. So you have these big, thick ropes of PDL, and they are sitting in this water, which soothes the stress or makes them more flexible. And they're made up of the loose connective tissue, blood vessels, and those fibers that we've talked about that support the blood vessel, so oxytocin. So interstitial area, it's like the cytoplasm, and that it's made up of loose connective, blood vessels, and oxytocin. Finally, epithelial cell rest of malaceae, which are the chunks of hard-twig epithelial root sheath. That happens when the connective tissue growth is way too fast for epithelial, so the epithelial break apart and they form these islands in the PDL space. And they're important because they help us in forming cementum and the PDL. So when the epithelial breaks apart, the dental follicle is able to interact with the dentin, and you start initiating cementoid, which is your inorganic, with the hydroxyapatite forming cementum, and that finally forms PDL. Lastly, we will talk about cementum. Cementum is your mineral component that covers the root. The function is anchoring the tooth, adapting it for proper occlusion, protecting the root dentin. And physically, we know that the cementum will be thicker in the apical region. So we said that is the cellular cementum at the apex, versus it will be thinner at the coronal, which is your acellular cementum. It's semipermeable, made up of organic and inorganic. Organic is your collagen and glycosaminoglycan. Inorganic, just like the tooth, is your hydroxyapatite. We know that we have to differentiate the difference between acellular and cellular, so the cells will be the only different. You have the collagen, hydroxyapatite, and acellular with the cementoblast, whereas cellular has the cementocytes and lacunae, as well as canaliculi for nutrition. And this might seem familiar to those who have seen the bone formation, because bone also has osteocytes and lacunae, so they are basically osteoblasts that get stuck or get solidified or calcified in there. So osteocyte and lacunae, and you also have canaliculi for nutrition in bone. So cementum and bone is very similar in other aspects as well, but their structure it looks very similar. So let's review real quick, spiral through the lesson, and then we'll do a spiral of some questions. So we have the bony component, alveolar crest, cribriform plate, cortical plate, and the spongiosa that is in between the cortical plate. We have the acellular cementum up top, which is thinner. We have cellular cementum at the bottom, which also has the cementocytes and lacunae. We have the PBL fibers that go from the top, bottom, apical, alveolar crest, horizontal, oblique, and then finally our apical fibers. And then we know that the bulk of the oblique fibers is for mastication, whereas lateral forces is for the top two, and the bottom last are for tipping or torque. We know that the origin is from the dental sac of the periodontium, and periodontium is only PDL, cementum, alveolar bone, and gingiva. It is a connective tissue organ made up of fibers and mineral component. The fibers is your lamina propria and the PDL, whereas your mineral is your bone and the cementum, which are very similar. We have the alveolar bone, which is the alveolar where the teeth sits, and the basal bone, which is the rest of the bone of the mandible or maxilla. It's maintained by the PDL. We have the alveolar bone proper, cribriform plate, where the teeth sits itself. That is the attachment of PDL, but more specifically, Sharpie's fibers that go into the bundle bone. Bone formation, intramembranous, endochondral. Intramembranous is for maxilla mandible. Endochondral is for the condyles, need a cartilage template. Then we'll go into PDL. Most important is proprioception, knowing movement and space. Two fibers, collagen, oxytocin for blood vessel. We have the fibers that go in the direction. Then we have the gingival ligament that the name tells you the location. The cells of PDL, fibroblasts, blood vessels, bone, and cementum cells. Finally, cementum, which is basically anchoring the tooth, has the thicker cellular cementum and looks like bone. So if we jump right into some images, we can talk about the concept. Here you can see that where the teeth will sit, as you can see, will be inside the bone. That is your alveolar bone. Everything underneath that, so the bulk of the bone is the basal bone. That is in both in maxilla and the mandible. Alveolar bone proper, aka cribriform plate, aka lamina dura in an X-ray radiograph. So if you take a tooth out, you see in the socket, you will see these holes, and those holes is where you will get this fluid nutrition for our periodontium, known as Volkmann canal. Next, we will go into, we know that there's spongy bone around the cortical plates. And once again, if we look at a picture of a tooth structure, tooth bone, we have the spongiosa in the middle, always covered by the compact bone on both sides. We have the alveolar bone proper, cribriform plate with its Volkmann's canal for nutrition. And if we look at histology, we know on one side we have this clear, straight lines, no cells, and that will more than likely be the tooth in our oral cavity, basically. On the other side, you have the bone, because it has the osteocytes and lacunae. And as you can see, that the Sharpie fibers are present on both sides, so they come from the cement, or from the in the bone side. They are in the immature bone, or the bundle bone, where they attach, which is on top of the cribriform plate, and they go into the plexus, intermediate plexus, and then on the other side go to the pericemental zone into the cementum. Either it's acellular or cellular cementum, depending on the location. So pericemental zone has those cells of cementum, whereas the bundle bone, we know, has those cells basically of the bone, osteoblast and osteoclast. So in the middle, like we said, is the intermediate plexus. That is important for tooth eruption, because this is where most of the breaking, joining happens, because you're in the interstitial fluid and things are more easier to break and rejoin, unlike where you're anchoring on both sides into the periosteal or the pericementum zone. So this shows more clearly the zones of PDL. You have tooth on one side, you have the bone on the other. So those will have your osteocytes and lacunae. You have the periosteal zone with the osteoblast and osteoclast. You have the pericemental zone with cementoblast and clast. If we talk about tooth eruption in relationship to the PBL fibers, we can see that as tooth has not erupted, there is no PBL fibers. So the most important is the PBL fiber, the collagen turnover mechanism, is what causes tooth eruption. So you start with these oblique fibers, basically, that are at an angle. Then you get the horizontal fibers, and then you get the alveolar crest fibers. And we can figure out that the last fibers to come are your apical fibers, or your intraradicular fibers. So that could be some type of a question, which is the first fiber or which is the last fiber to show up. And you can know that the apical fibers, which are not seen here, usually will be the last ones that anchor the tooth down once everything is complete. So you need the root formation to happen. We have intraradicular fibers that go from the septum to the bifurcation. Here we have the bone, so this is your alveolar crest, and you have tooth on one side. So you will have the PBL fibers that will run from the alveolar crest straight up into the tooth. You can have horizontal fibers after that. Both of these are for lateral forces. And then you can have some interstitial fluid in between those. Here we can see oblique fibers. The next fiber is a little better. So you have the bone osteocytes on one side, you have the tooth on the other side, and you have these that go in coronal direction from the cementum. From the tooth, they always go up. So those are your oblique fibers, and they do the bulk of the work, which is mastication. Here we're looking at a tooth from the bottom up. So if we're looking at the root canal, and we're looking at the circular fibers that are surrounding that, as well as the apical fibers that are attaching to the root. Here we have the gingival ligaments. We talked about that the name tells us the location. So circular fibers are wrapping around the tooth, and we said we usually find them around the implant. So they wrap around the tooth, so that's why you see the dots, because we have cut a cross section. Next we have the alveogingival, so they go from the alveolar crest to the gingiva. Dental periosteal go from the tooth to the periosteal bone. Dentogingival goes from the tooth to the gingiva. So this will basically anchor the gingiva in its place. Here you have the cribriform plate, alveolar bone proper, or known in this x-ray, we would call this lamina dura. And once again, this is how you tell bone loss. Here you can see better picture of septum. So you have the interdental septum, and interradicular. So interradicular inside the root, interdental in between the teeth. And you can also see other components like that cribriform plate or the PDL space, so on and so forth. And finally, we just compare and contrast our cementum and the bone. We now both have the cementocytes and lacunae, and we have osteocytes and lacunae. And then we also have the canaliculi for nutrition. Those basically are outgrowths, or like lines that go from these from the lacunae. And that is